Thanks, Michelle. And thanks everyone for joining. It's great to see everyone. I know it's almost the beginning of summer and we're soon going to be hitting the thick of it with people traveling back and forth. But we're really glad that you could join today. And I'll turn it over to Courtney for opening remarks.
Thank you. Good evening, everyone. I'm Courtney McFadden. I'm the Deputy Director for the Prevention and Health Promotion Administration at MDH. I want to again thank everyone for continuing to participate in the Diabetes Quality Task Force. There continues to be a lot of work that needs to be done to address diabetes. MDH, the administration, and the Cancer and Chronic Disease Bureau have been working hard to align our diabetes efforts with Governor Moore's healthcare priorities with a strong emphasis on health equity. HIPAA and CCDB are committed to embracing health equity as a core mission to help Marylanders live healthier lives. Both internally and through partnerships with community stakeholders, MDH has focused on ensuring that health equity is incorporated into all of our activities. The Diabetes Communications, Education, and Outreach Campaign will allow us to build awareness through a health equity lens, focusing our efforts on people who are at most risk. Additionally, the MDH was awarded MDH was awarded the diabetes grant application as titled, and it's a long title, a strategic approach to advancing health equity for priority populations with or at risk for diabetes. This will allow MDH to focus more on health equity in the identified priority populations that have higher diabetes prevalence and mortality. Lastly, I wanted to take a moment to mention we have a new administration director, Dr. Elizabeth Crum. Dr. Crum comes to us with a strong background in health policy and management, and we're fortunate to have her expertise as we continue to address diabetes in our state. And now I'll turn it over back to Dr. Kaliani. Thank you.
Thanks so much, Courtney. It's great to hear about all the updates from the new administration, and we really appreciate you being here to share those with us today. So to remind ourselves of the mission of the Diabetes Quality Task Force is to improve the health of the communities we serve through coordinated and meaningful initiatives to address the prevention and management of diabetes in Maryland. As a collaboration of organizations and partners across multiple sectors, we come together to identify opportunities to improve health outcomes in those identified or at risk for diabetes or diabetes complications. We will act in our areas of influence to align efforts and resources to reduce the burden of the disease. So we have a really exciting agenda for you all today. And up next, we have Maisha from Care First, who will share diabetes activities from her organization.
Hello, good afternoon, good evening, everybody. I'm Maisha Dion-Cover, and it's nice to see some familiar faces and names. I am with Care First with our Community Health and Social Impact team. And I also have the pleasure of working with Michelle, Pam, and Lisa on our CIHIS efforts. And so I'm just going to provide just an overview of some of the things that we're doing here at Care First to really address wellness and well-being, also with an emphasis on diabetes. So Michelle, do you want me to share my slides or do you want to share them for me?
I can have them. I have it pulled up. So let me see. Let me share mine.
Oh, okay. That works.
That way
okay.
You can still focus and just tell me when the next slide.
All right. Well, now you can definitely go to the next slide. Yeah.
Okay, good. Let me make, come on. The change.
All right. And so obviously this group, is very well versed in health equity. But I also just wanted to just mention that at Care First, really, we have shifted a lot of our efforts to really think about how we start to approach health. And particularly with, I sit in our Community Health and Social Impact Department. And so we've really worked over the last 3 years to move from a lot of transactional care to really transformative. And with that, a real focus on meaningful engagements with the communities that we serve, as well as working really closely with our partners. And so I just wanted to kind of bring this slide up and just really making sure that, we called out the role that Care First has in being a partner for change. And I think it's so critically important with the work that we're doing around diabetes. And I think it's been really wonderful to explore what some potential partnerships could be with the Department of Health and even some of the local health departments that I will talk about. Also, knowing that we really need to take a comprehensive approach as well as start to address systemic racism as a real central role to a lot of the inequities that we see. Next, please. And with that, also mentioning that, Care First is engaged in this work, but also we are part of one of the 30 plus Blue Cross Blue Shield Association plans across the country who have adopted this national health equity strategy. And so the Blue Cross Association has just started rolling this out over the last 2 years and really thinking about the role that all the Blues plans play in addressing racial and health disparities. They're currently focusing on maternal child health, as you see at the bottom, but they are going to be moving into diabetes and cardiovascular conditions, as well as behavioral health. And within this strategy, it aligns with a lot of the work that we are already engaged in. One is leading with data and using data to help measure a lot of inequities, thinking about like what are some best in class programs and ways that we can adopt those across the country. The role that we have with providers, especially around unconscious bias and increasing provider competence with varying populations, the partnerships levels, and then also last but definitely not least, our role in policy. And I think with Care First, and we are the largest insurer within the region, and so really we have a critical role to play in leading all of these efforts, and we take that role very seriously. Next, please. And so kind of thinking about our role, as I mentioned, we really are hoping to think about it very comprehensively. I sit in our community health team, which really leads a lot of our community investments. But in addition to that, I have the opportunity to work with a lot of our member-facing activities as well as our employees. And so thinking about all the different ways in which we are intersecting as an organization to address health disparities. And so just want to speak to a couple of these things, and I'll touch upon this with some of these other slides. But kind of looking at like social determinants and a lot of the social inequities data is really driving that. We can definitely speak to this at a later meeting, and I can share some of this, but this is really work that's being led by our colleagues, Dr. Gingy Lindsay, who heads up our public health team, along with Kirk Allen, to really partner with Socially Determined, which is a social analytics firm that's really looking across our member population at community level risk, individual risk, and how we're using that and coupling it with a lot of our quality data to really assess where their needs are, different insights, and then also potential interventions across all of our different groups. And so that is the work that we are engaged in, but definitely is developing. Data is always a need for everybody, and we are not unlike anyone else. And thinking about working with our providers, I'll talk a little bit about some of the value-based work that we're doing, the investment work, which I lead a portfolio really kind of focused on diabetes, which I'll also mention, and then also thinking about the partnerships that we have on our state, regional, and also different community levels, and then our policy team. So that is really kind of how we are working. We have teams have very actively engaged in all of these efforts. Next, please. And so just talking a little bit about our value-based program. So this is really for our commercial population, but it's also looking to extend into some of our government programs as well. So our practice and payment transformation team has developed a series of health equity trainings. The first trainings focused on structural inequities and structural racism and implicit bias, and they've actually been rolling out a number of different kind of modules for providers so they can access them, and actually anyone can access them through our Learning and Engagement Center. There's some new modules that are just rolling out around LGBTQ health, in addition to some other areas, but with the hopes of actually having the upwards of 30 different modules and accompanying resources for providers and to take just to kind of help build their competency. We're also working with a number of the healthcare institutions to evaluate their current offerings and either enhance that or add some of their resources to our list. And so that's some of the work that we're doing with providers that we know is essential. Next, please. And then talking a little bit about the offerings that we have for our members. So we have a pretty robust well-being program, and this is actually just revamped and rolled out just this past January. You can go to the next slide, Michelle. And so in addition to kind of some of the well-being offerings, one of the things that we are hoping to do is really increase our communication with members so that they actually have a real good sense of what their care needs are, as well as preventative screenings that they need. And so this is also another initiative that was done, really led by our quality department, really looking at a lot of the HEDIS measures and where we were kind of falling short. And so these are individual reminders that go out to every single member annually around different health screenings that they need to have. And as you can see on the right-hand side, smiley face if like you're happy or sad, but then it also has connections for them if they have not had a visit with their provider, and the opportunity for them to schedule that wellness exam, as well as additional communications that we have in our well-being platform. In addition to if people don't have a provider or kind of in limbo of a provider, we also have a new online virtual provider tool for members that we can also offer. So like kind of before we get into any of the like services we offer around chronic disease prevention or management, making sure that we are kind of flagging the needs of our members first. Next, please. And so this well-being app is an app, and it also can be accessed, through the regular web platform. It allows folks to complete a real age assessment, so kind of like what their current state is of health and wellness, and so they get like their real age versus their actual age. But then there are also different suggestions it'll provide if you can enter challenges for tracking your sleep or different things, but then it also connects them to a number of the other programs we have. So health coaching, which is coaching that happens like virtual coaching when someone will call you, weight loss, which I'll talk about, any type of cessation programs, financial well-being. And so really thinking comprehensively about like really what wellness looks like for an individual, and kind of having like one stop shopping for them to access all those tools. Go right ahead. And so the health coaching, we really do a lot of work, particularly with our members who are either pre-diabetic or diabetic, to have like our lifestyle management and disease management coaches available to them. And so people can opt in for these on their own, or it could be by provider referral, or sometimes they will get flagged if there was like an admission or any kind of incident. Sometimes people might get flagged just to get reached out to by a coach and saying, are you interested in this or not? And then they can set up weekly or monthly kind of one-on-one coaching calls in which they connect them to different resources, online, local resources, or anything, and just to check in with them and just to kind of help hold them accountable. So this is a resource that some people take up or not, but it's an offering that we have. But it can be particularly helpful around some disease management and with med adherence and things like that. So that is something that we have offered. Next, please. As I mentioned, we do have a primary care program. And so this is a new offering around making sure that people are connected to care. This is actually also was recently rolled out with our Medicaid plan. And so it's available to a larger group of folks. And I will answer that question at the end. I can't quite read all of that. But one of the things that we wanted to make sure that people had access to was a provider, and if they didn't need it in either an urgent way. And so our close-knit team does preventive urgent care, as well as we can do behavioral and mental health care, as well as connect people. And it's really anytime that anyone needs care. So it's been a nice additional resource to provide to people. And I think, we've had for folks who aren't always connected to care, or maybe have had a gap in care, this has been a nice service to help connect them. Next, please. One of the newest offerings that we have is Noom. And so this is just the regular Noom platform that everyone might be familiar with. This is a new tool that CareFirst just adopted this past January, really focused on diabetes prevention. And so really using cognitive behavioral therapy to reach folks in addition to like the regular Noom platform. And so it's personalized. It has lessons around nutrition and fitness, in addition to logging of exercise, as well as food, as well as motivational support with an individual coach. And so this is something that is really directed at another option for folks around diabetes prevention. And so you can go into the next slide, Michelle. And then in addition to Noom, we also have this new kind of revamped program called Eat Right Now, which used to be called Scale Back, which was our diabetes prevention program that we had formerly. And so this can be used in combination with or instead of Noom, but it's just another offering. And so it's an app as well. And it really is focused on mindfulness related to food. And so this has been, I think, really helpful for folks, and we've gotten some great feedback around it, just in terms of the mindfulness and kind of the food connections and the mental connections with food. And so as you can see, it's 28 modules that are offered all virtually, and then there's interactions on the app, and you can also do some meal planning, tracking, as well as progress around any other physical activity that you do. And so these are kind of our diabetes prevention offerings that we have in a virtual space for folks. Next, please. And for those who actually are uncontrolled diabetics, this is a program that we adopted a number of years ago called Unduo, and these are really aimed at management of diabetes. And so this works again virtually, but then there's also some individual coaching that happens. In addition to the coaching, folks also get a continuous glucose monitor, as well as test strips to help manage their blood sugars. And then they also are accessed, they have a specialized care team that also helps with their management. And so, we are hoping that, folks don't get to the stage in which they have uncontrolled diabetes, but if they do, then there's this Unduo option that we have for our members. So this is another thing that we have in addition to the prevention programs. Next, please. And just a little bit about our Unduo. As I mentioned, it's uncontrolled, so an A1C over 8. If there had been a previous hospital admittance, or if someone had not had a primary care visit. So those are kind of really the members that we are targeting with that. And initially when we rolled this out, it was about 33,000 members that they target, and annually they survey our membership and then continue to reach out to folks. There is some exclusion criteria. Unfortunately, there isn't anything particular for uncontrolled diabetics if they're pregnant, but we are doing some other disease management tracking for them. All right, next, please. And then kind of moving on, so away from a lot of the prevention work that happens in the clinical space, I also wanted to provide an overview of the work that I lead, and as we think about the partnership piece and the role of communities and really moving the needle. Next, please, Michelle. And so you may or may not be familiar. So within community health and social impact, I've mentioned that we really are trying to take an approach of starting to address social determinants. These are the 6 areas in which we work, community health and social impact, which also aligns with a lot of the work that Care First is doing along with the Blue Cross Association. So we really work along the range, knowing that all these things are interrelated. A lot of the work that I previously mentioned is really trying to get towards the accessible, affordable, high quality care aspect of the work that we do. But we've also tapped into the chronic conditions with some of the grant funding that we're doing around diabetes. We also have a number of different grants that we've put out actually just this past year around economic inclusion. So thinking about workforce development and making sure that folks have a livable wage as a role in addressing some of these inequities, as well as behavioral health. Recently, we had an RFP that was released focused on youth and also increasing workforce. And then also within the work that we do is really around this engagement piece with our communities. And so our volunteer engagement and our corporate social responsibility also falls into this as well. And so this is also another lever that we feel is critically important in the work that we do. Next, please.
Hold on a second. I don't know why it's not changing.
It's just
Yeah.
slow. It's
It's
after
the-
5.
Yeah, it's exactly. Okay, there we go.
And so with the recent grant making we did, it was really targeted towards LHICs. And this was just to build upon some existing funding that the local health departments had received. So LHICs in Maryland, but then also all across our region. So Maryland, DC, and Northern Virginia, aimed at 3 different areas, really thinking around like collective impact to start to address the upstream determinants of diabetes. Um, Grantees ranged in terms of where they applied. However, most of the grantees are really in the collaborations or partnerships phase, which is that middle box, and really thinking about what does authentic community partnership and engagement look like, and really working towards the strengths and assets that a community has. And so most of our grantees in that category are really working on building relationships with communities, and then thinking about how you can make those connections and partnerships between communities and hospitals and health systems. So as you can see, there are a number of different local health departments that were part of this grant program. These are actually ending up being almost 2-year-long grants, kind of planning grants for the first year, and then another year for them to be able to implement their interventions. And so some of the different areas I mentioned, like food is medicine, programs, community gardens, a lot of programs trying to assess one, and then address food insecurity in their populations. And many of the grantees actually have selected really specific communities or zip codes that they wanted to target with their programs. And so that is the work that there is ongoing. You can go to the next slide. So just to give you a sense of where they are, we have 1 grantee out in Western Maryland in Garrett County. We have a number of grantees on the Eastern Shore, Mid-Shore, all the way down to the Lower Shore, so they're really well represented. Probably not surprisingly, a great number of grantees in Central Maryland, and so that's Baltimore City, Baltimore County, all the way up through Cecil County, which we actually consider Central Maryland, and then also in DC and then Northern Virginia. And so these are really some of the areas in which people have worked, which I've mentioned previously, but really, availability and accessibility of services, tailoring interventions to really meet the needs of their population is the work that's ongoing. Next, please. And just, a little visual of like some of the work that's happening. So these are some of the community gardens, the physical activity that's happening. Some really interesting programs and partnerships that our grantees have made. The farm to library programs in Worcester County, and it's a partnership between the local health department, the community college, and the public library, and really focuses on workforce development in addition to diabetes prevention. So really collaborations and partnerships is at the core of this work, and really getting folks to move towards, as I mentioned, a collective action. Next, please. And then lastly, I also wanted to mention, you can go to the next slide, Michelle. Some of the other efforts that CareFirst has been engaged in that kind of encompasses all these efforts. We recently, in this past October, opened a CareFirst Engagement Center, which is right at in our Baltimore headquarters in Canton. And so our Community Engagement Center is open to our members and the general public, and really is around these core values of sales, service, community, and care. And so it's an opportunity for members to engage in their health insurance products and find out what their benefits are, how they can best utilize them, and really help people navigate the complexity that is health insurance. We also have a number of different community partners that we engage. We've hosted like the Centering Pregnancy site visit that recently happened with the Department of Health. So there's those activities that happen, but then also different nonprofit partners come in. And then we also have services, like clinical services that we provide through Close-Knit there. You can go to the next slide really quickly. Next slide, please. We're just mentioning just the kind of some of the calendar. This is an old calendar, but it's pretty much the same thing, and there are new things that are always being added. So we have like wellness Wednesdays. We have fitness programs specifically for moms every week. The Community Thursday is actually open to a different community partner, but we have a lot of community partners coming in, doing stuff around healthy food. We have a decoding diabetes class that happens, a hypertension management class. So really providing a range of resources for members in the general public to come. And so I will provide a link for this to Michelle, so you guys can, if you're interested, check out the calendar, because it's updated with new things all the time. So it can be another extension of the work that can be really helpful. So wanted to share that as well. And with that is everything. So I know there's some questions, so I will try to answer them.
Do you want me to read them out to you, Maisha?
You can. I'm scrolling up.
So the first one says, obviously all your members have access to medical care. What is the most common barrier you are finding for not achieving goals for both primary and secondary prevention?
I mean, I don't know that we have any barriers that are probably any different than anyone else. I think, folks not always accessing care, also even knowing about their benefits and the services available to them. So I think that is something that we hear often. And I also think, particularly in some communities, right, like lack of trust and connection. And so I think that's also one of the pieces, is right, making sure that we are better connected to our members and more responsive to their needs, which is something that I think have had some work to do and have made some great inroads with. So I think those are the ones that I hear often, but I also kind of sit in the community a lot more. So probably have a very different perspective than some of my other colleagues.
Hey, so Care First has been stressing these points for years. How is the program, except for the use of modern technology, really different? Admirable though the goals may be.
So I think the community engagement work and the work that we're leading through our investments around place-based work is very different. And so I think that is really has the opportunity to, one, inform the work that they're making within the business in terms of a lot of the wellness options and benefits for our members. I think also with the recent addition of our Maryland Medicaid program, I think there is a different level in which we're actually looking and examining all the different factors that impact people's health that we haven't actually started to address. So and I think that has also been raised, I think it's a great point around the technology, but who's the technology accessible for, and making sure that everyone has access to it. And so that is something that we're very aware of. But I think kind of the work that I lead within CHSI and our community health team is having people work a little differently. And it's been interesting working with our local health departments who, I have given them a little bit of freedom with their grants just to really engage with communities. And it was a little challenging for some because it's not how they've worked. And so I think that is what is new. And it's been interesting to see kind of how things have evolved or shifted based on kind of what having the community work lead first versus what I think the program thought were the needs. So that's been interesting. So hopefully I answered that.
Reaching chronic disease goals has a series of
Dr. Mann, what are you doing? I kept trying to read through the question.
Ability to pay for care, insurance or other, available provider, seeing the provider, getting the right evidence-based treatment plan, then executing the plan at home, which then has knowledge, motivation, and capacity issues at home. The barriers can occur at any of these levels, and the disparities can occur at any and the disparities can occur at any of these levels. And some barriers are at the individual level and some are at the community level.
And so Dr. Mann, is your question so the comment first, and there's a question then around the data to accompany some of these barriers that were mentioned?
It was more to kind of put a framework to answer the previous question, which was to say, where do we think the barriers are? And I thought it was probably one or more of that list was just kind of a contextual comment. But then I have another question, which is whether you've got data on the equity of uptake of these various programs.
Yeah.
Because my experience watching people use bike lanes is it's always healthy, skinny people using bike lanes. It's never the people we need to actually get more exercise to reduce their obesity using the bike lane. So that's one example of an opportunity, but the uptake is not where we need the uptake necessarily.
And yes, and so I think there are two different sets. So for our grantees who are doing interventions around like either diabetes prevention or physical activity, yes, they do have data around equity to like and know if they're actually moving the needle. And there have been some promising results and outcomes, but like it's only been a year, and so there's that. And then I think in terms of some of the different other options, so with our Scale Back, our Noom, and our On Duo, which are the diabetes prevention and management programs, they do have some data with that, but not a lot. And so they actually, with the addition of Dr. Lindsay and the public health team, are really working to build out the population health integration into those measures, because that is not something that was as robust as it needed to be. So it's happening. Yes. And then I see Elizabeth, you have your hand
Yes.
up.
Thank you. Thank you. Thank you so much, Maisha. You mentioned about also the Medicaid program. I know that I have Care First for dental and I also have it for, my other coverage. Particular for the Medicaid, Medicaid patient. Now that with the dental, right, dental coverage is allowed. I know that the departments, we might not necessarily have enough providers. I'm just thinking about whether or not in any of your program has kind of cross referral in some way, like, seeing that, oral health definitely is very important. And a lot of problems starting with oral health, and then here without diabetes, patients, what do you see that potential interface of, these two offices for primary care and dentists?
Yeah, no, I think, no, there definitely is some intersection. And I know, so we have actually provided some funding to some FQHCs across the region around dental services. And so I know that working with those FQHCs, they actually were also looking at chronic conditions and kind of look in tracking patients with that. And so that's not something that I can speak to as much. I'm just somewhat aware of it, but I know that they were actually exploring kind of how can a lot more coordination and collaboration happen, and then also tracking of outcomes with that as well.
Thank you.
And then I see Matt's hand up as well.
Good evening from the Eastern Shore.
Hi.
I enjoyed your talk. My question is, what other programs do you have going on the Eastern Shore? Community gardens are great, and engagement is wonderful, but Somerset County has the highest rate of diabetes in the state. What else are you guys doing?
So in Somerset, the health department has a grant to do the diabetes prevention work. So that is what we funded them to do. And so they're probably like a year into the grant, and so they have probably another 6 or 9 months to go. They were actually looking at food insecurity and addressing that. And so that is something that they were building out, but it was really community led. One of the things that they were doing is trying to figure out how to partner with some of the local farms to address some of the food needs of the population. And then also kind of what the residents wanted were recipes. And so connecting them around so we've talked about in the DPP around like cooking, but like I've tailored this. And so actually they developed a recipe like book that they kind of put together. And then they're actually working with another external partner around canning too, because then thinking about preserving and just kind of some of those old traditions and that people actually have some knowledge of, kind of going back to that. So that is what they are doing, but that was all, dependent on the work that they did, from the health department, working with some of the community partners and residents.
Okay, thank you.
Sure. But yeah, I mean, they've been great. It's been a little slow there for them to kind of like get going, but I think they have some good momentum there. And I think that they're actually poised to like, get additional funding for some other things, because they were like talking about, working with MAC and then also working health. So I think they have some different ideas. And also the other thing they were trying to do is also work with faith-based leaders there, is to expand the work with that population.
Okay, well, that's excellent. And what sort of uptake do you have with the Noom platform with across your membership? Do a lot of people know about it, or is it your best kept secret?
No, it's new. So it just got rolled out in January. So it's not even 6 months old. So actually no, not even January. No, actually I lied. It was April. So it's very, very, very new. But we are going to like be tracking uptake. And also really, I think kind of to the equity point, right? Like who's accessing it, and what kind of outcomes are we getting. And so that is something that we're also really into to find out. Great.
Does anyone else have any other questions?
I think there was one more comment, just a general comment from Dr. Carney. Not having a bike lane safety will give obese individuals one more reason to not bike. And then Monica did share the ADA Food Hub, which provides guidance on food and recipes.
That's cool. Thank you.
So Maisha, you mentioned both Onduo and Noom, right, as apps. So are you going to compare them at all in terms of their uptake, or?
I actually don't know. That's like it sits in the wellness team. It does not sit within me, so I am not sure. I imagine they are going to do something because we have so Eat Right Now is like the former program we had was Scale Back, and then Noom is like the newer platform, and so they kind of do the same thing. So I believe that group is really looking to see what the outcomes were with one versus the other. And then Onduo is for uncontrolled diabetics, which I think has been hard as a virtual program. And so I think there's a real opportunity for us then to really leverage, some of the existing diabetes self-management programs, which might be more impactful. And so that's also the work that we're trying to do as well.
So Matt had another question. Can any of your members use Noom?
Yep, it's available for most groups, and I should have caveated some of these things. And so, in terms of the different offerings, like the ones I mentioned are available to like all Care First members, with the exception of our federal employees. There are some differences with that, and then some other members. But for the most part, the majority of our members have access to all of the services.
So is there a link that members can go to download it, or how does that work?
Yeah, so if you go, so if you're a Care First member, you go to carefirst.com/wellbeing, and it has a list of all the different wellness solutions, and then you can click on any of those options and download the app, and you just have to log in through the Care First member.
That's great. And I'm sorry if I missed it, but did you say what percentage of your population has diabetes?
That is something that I have, it's an older number, but yes, I did not mention it because we do not have updated numbers that I could share right now.
I mean, I imagine it'd be similar to the statewide prevalence. I'm just curious if it might be even higher just because of the populations you cover. No.
Yeah, no, it is not dissimilar at all.
Okay. I think there's a few other comments, not so much questions. Right. So David had a comment about walking versus running programs. Yep. And
yeah, and I think just kind of to that point, I think some great success that we've had with some of our grantees out in Garrett County. They have really started this whole Garrett County in Motion campaign, and it started right with walking, but they also have a host of other activities, and just the engagement that they've seen is really tremendous. And they also have seen weight loss and then changes in BMI with folks who are actually utilizing those programs. So right, I think it's like the varied activities, and then once you actually have someone engaged in one thing, then they do other things, and it really ranges in terms of like who's participating too. So I think folks that maybe you wouldn't have traditionally thought about participating in the programs are and doing paddleboarding, and then also showing up for yoga. And there's this really interesting community support that is really building, and there are new partners and new people who are participating. So I think, right, just increasing accessibility and availability. So I think that's a great example of what's already happening. and it's also being replicated in some ways in different places. And Matt, I saw you said something about walking. I don't know if you're in Somerset, but in Worcester, they actually are doing like a trails program that they're really trying to get kind of countywide take with to really increase walking and kind of make it a countywide initiative. So that's also another component of work that they're doing with us.
Well, Maisha, thanks so much for all your thoughts today. I want to make sure we have enough time for the rest of the agenda, but it's so great to hear about all the well-being initiatives that Care First is doing. So congratulations and thanks for being here today.
Thanks, my pleasure. Take care, everybody.
Thank you, Maisha.
Thanks, Maisha. So next on the agenda, I believe we have Pam Williams. Is that right, Michelle? Yeah, I don't see the agenda shared, but that's okay. So Pam is going to share some exciting preliminary views of the diabetes dashboard that the Health Services Work Group also helped contribute to and give input to, and quite honestly has probably been the main tangible outcome of the quality task force to date. So really excited. I saw some prototypes and some previews of this last week when I met with Michelle and Pam, and really excited to have you all see it and get your input. So Pam, thanks so much. Looking forward to your presentation.
Okay, thank you. I apologize. I'm going to have to be on video because of the slowness of my computer. So my name is Pamela Williams, and I'm the director for the Cancer and Chronic Disease Bureau at the Maryland Department of Health. So today I'll be discussing the diabetes dashboard. We were tasked with developing the diabetes dashboard a few years ago. And so the original purpose when we were tasked with this were a few things. One, we wanted to get a better understanding of diabetes in Maryland, and we wanted to identify and track measures, quality measures for a diabetes dashboard. It is also an expected deliverable for MDH leadership to track how we're doing with diabetes, so the progress and outcomes. And then we also wanted to develop interventions for stakeholders to address problem areas. Next slide, please. So this is just a brief timeline for the diabetes dashboard. So when we launched the Diabetes Quality Task Force in 2021, we did develop work groups. So two of the work groups were the ones identifying and developing the quality measures. So that was the Health Systems Interventions Work Group and the Data Evaluation and Surveillance Work Group. Once we've identified the quality measures and identified some potential data sources, we worked internally at Maryland Department of Health with the data office to develop the dashboard. So really looking at obtaining the data, working on a platform and the data visualization. So we are now at the final stages of completion of the dashboard. Next slide, please. So this is the landing page for the dashboard. So we wanted to have three different focus areas. So we wanted to do population measures, clinical measures, and hospital measures. So I'm going to focus on the population measures and share the hospital measures. We're still fine-tuning the clinical measures right now. So for the population measures, where we landed was having diabetes, diagnosed diabetes prevalence, diabetes mortality, obesity prevalence, ever attended a diabetes management class, taken an A1C test within the last 12 months, taken a dilated eye exam within the last 12 months, and taken a foot exam within the last 12 months. And so the way this works, if you click on the population measures, it will take you to, if you go to the next slide, it takes you to this area. So this is the diabetes population measures. So it lists all of the measures. It has the value, the margin of error, and the current slope, the year, and then it talks about the status. So are we improving? Are we getting worse? So if you look, I'm going to focus on the diagnosed diabetes prevalence. So if you clicked on that within the dashboard, if you go to the next slide, please. This will take you to a graph. So this is the age-adjusted adult with diagnosed diabetes prevalence. So we do have it stratified by race. And then so you can actually click on the race if you want to focus on a particular race, or if you want to have all of them, you can do that as well. And then we also have a map, the prevalence map. So the darker areas highlighted are the areas where it's a higher prevalence. So we have this for each of the measures for the population measures. Next slide. So this is just a snapshot of the hospital measures. We are working on getting updated data from Chris. And so this just reflects data we got through CDC, but this has an example of the age-adjusted adult inpatient visits with diabetes. And we also have this stratified by race as well. Next slide. So in terms of the next steps, we are finalizing data for the hospital measures, and then we're going to continue working on updating the data visualization for the clinical measures, and we're preparing to make this available for the public. And I believe that's the end of my slides. Okay, I'll turn it back over to you, Rita.
Thanks, Pam. This is really exciting, and especially to see the granularity by county, by region, to see the trends over time. I know we talked a little bit about this when we met before, but I wonder if you could share with the group what plans MDH has for the dashboard in terms of how it will be used going forward.
Oh, I'm sorry about that. So we do want to discuss this further with our work groups, so the health systems and data work groups that help identify and develop the measures. So we do want to talk this a little, in more detail in terms of what the next steps will be. But we do want to make this a public-facing dashboard. That is the goal. So this will be helpful for different stakeholders throughout the state.
Great, and I think, to track the effects of interventions in the state, whether they're through MDH or even other organizations, will be really neat to see over time. David, you've had your hands up as well.
Yeah, I've been part of the team that's been working on developing this. So just a couple of thoughts I wanted to make sure everybody understood. One is the charts have multiple lines, but you are able to select 1, 2, or 3 lines at a time to make the chart have less spaghetti on it at once, which I think make really easy pairwise comparison. So if that looked a little crowded, you can select it so it's not as crowded. And the other part would be, you see we've got the trend lines through the up and down sawtooth of the data, which just I think helps to emphasize the fact that all these things have a certain amount of somewhat random year-to-year variability around what's probably a more stable set of public health and health fundamentals. And so just to emphasize that, don't get too excited about any one-year change in any one direction, because it could easily flip around and go the other way in the next year, and think about the long-term trends more than the one-year changes.
Thanks, David, for that insight, and also for all your efforts in creating this beautiful dashboard and the data, which is so important to have to create the dashboard. Does anyone else have any other questions about the dashboard or comments? We'll also talk more about this in the health systems and data work groups too. Okay, well, I know that we're going to have continued conversations about this in the coming months, but Pam, thanks so much for all the efforts of your team and all the work that went into that dashboard. I'm not sure if you had mentioned, but the only other state I think that we know of that has such a dashboard is Minnesota. And so this is really going to place Maryland as, I think, a leader among states in terms of how we monitor diabetes and indicators of diabetes quality within the state, and really could be a model for other states to follow as well. So this is great. I'm really excited about it. Michelle, are we in work groups now, or what's next?
Yes, so we're going to go into work groups. Nancy's going to open up our breakout room. So we'll have our community clinical work group in one room, and then the other one will be the health systems and data work group that will be going more in depth with the clinical measures. And
Wonderful. Yeah, and thanks everyone for being here today. That we're going to break out now into our small groups. Our next meeting is scheduled, I believe, for September.
Yes, I can give you that date. I think it's September 14th, 15th. Let me look. September 13th.
September 13th. It's hard to,
Same place, same time.
yep. Hard
Thank
to
you.
believe, but it'll be here sooner than we know it. So I hope everyone has a great summer, and we can now move to the work groups, the breakout groups.
Thank you.